Welcome back to the PainExam Podcast. And today we're doing a webcast, and I'm honored to have Dr. Phillip Kim, who is CEO and founder for the Center for Brain Care, Interventional Pain Medicine, Multidisciplinary Approach to Pain Medicine. He's board certified in anesthesiology, integrative pain care, integrative medicine. He's also the past president of Pennsylvania Pain Society and involved in Socioeconomic Committee for NANS. Previously with NASS, SIS, and the secretary and future president of the Federation for Pain Care Access. Welcome, Dr. Kim.
Dr. Rosenblum, I can't thank you enough for allowing me to be on your podcast to discuss this Federation of Pain Care Access and some of the issues ongoing in terms of what this is. It's easy best for me to go over some slides here on our federation here. Let me get to that.
Sure.
Can you see that, David, Dr. Rosenblum?
Call me David, please.
David.
I actually don't.
Let me see it. I go to share screen.
Sure.
All right.
There we go.
There we go.
Just I see a clip, a quarter of the actual screen. So you might want to just.
Yeah, I'll expand it here.
There we go.
Okay. 1 second here.
For those of you who don't know, the FPCA is a mission-driven nonprofit organization dedicated to promoting access to emerging and standard of care pain treatments through advocacy and legislative solutions, fostering patient-clinician relationships. I mean, this is something we need. There's definitely a lack. It's a nonprofit organization, and Dr. Kim's going to tell us more about that. But I asked him to come on the show because I really think this is a worthy cause. Right?
Thank you, David. So the Federation Pain Care Access was, as per its mission, really looked at the understanding that there have been a field of pain treatments when we're trying to continue with its care with advocacy and legislation. In many ways, this was a group of physicians. We started this to understand this proliferation of restrictive care coverage, which is harming patients and the practice. We identified there are ways we would normally go do this, and in many ways, we do believe in standard care and scientific literature help guide our process and treatments for patients. But we also know there's an art to it, and that's one of the things we understand in medicine. The thing that we've not done well at this over as physicians and medical societies is really be more proactive in the social media and to really identify how chronic pain and acute pain are needs that need to be addressed. And in many ways, through our society, we need coverage for these for patients. Now, for people that don't know, treatment coverage is very complex. There are we call local care determinations in different regions and different sections in the country through CMS, Center for Medicare and Medicaid that cover. Then we have private cares outside of the federal coverage. We try to get coverage for patients. What I also know, there are now independent companies called Evicor, AIM, Optum, which help guide these commercial carriers on what should they cover or not cover. But I would also tell you, if you didn't know aside, Evicor example is really an entity which has a conflict of interest. Evicor is paid for and owned by Blue Cross Blue Shield, yet they do Blue Cross Blue Shield predeterminations for the interventional pain care. So why that's a big conflict that I see overall. They're being paid by Blue Cross Blue Shield to do their own independent and predeterminations. When they say we're not winning because we are having a big problem in terms of getting coverage for these patients. And ultimately, we're not winning because we still have an issue with the opioid epidemic. We still have an issue with coverage and different options. I always ask, and you ask yourself, if you don't do this what the doctors recommend in terms of these treatments, what are your options? What can you do for them? And that's where I think we're not winning, and this really hurts the patients. And I can show you examples where the carriers, even though we have experts, we have published recommendations, guidelines for these types of treatments, and you got experts on multiple societies to approve this, recommend this. The carriers will not listen. They have their own means of getting coverage for these types of treatments. Now, AMA, American Medical Society, did a prior authorization survey with physicians. And it's interesting that when you look at the survey, this is stark contrast. 33% of physicians report PA has led to determinations and the process of serious adverse events, whether it's hospitalization, whether it's treatments, and they believe almost 10% of patients have run to a disability and permanent bodily damage.
Oh,
I'll give you a good example. One of my patients who has cerebral palsy is bedbound in a wheelchair. It took them 7 months. They haven't done it yet. For 7 months, patient family was asking for a crate mattress to help with decubitus ulcer prevention. For 8 months, a mattress to help prevent decubitus ulcers. And guess what? Last month, I just found out she has a stage 4 decubitus in the bottom, and that's going to require more than just spending a few $100s for a mattress to help prevent ulcers. Now she has an ulcer stage 4, which basically means it's to the bone, is a high risk of causing mortality and problems with the patient. And that can be easily solved by just getting this approved.
right. Wow.
Um, Now, I can tell you the survey, when you look at this overall, when physicians are asking questions, there is 94% report a care delay. 94% of patients, almost every patient provider sees that. And sometimes physicians, they just put their hands up like, I give up. 8% say it may abandon treatments or try some alternatives, but that's a harm for patients. That's a huge number. When you get over 90, 80% of physicians saying this is a problem. Now, when physicians tell you about this, and this is what you have to understand. Physicians on the average will probably they do on the average about 45 of these pre-authorizations a week. Now, for my practice, we're probably doing 10, 20 per day. Physicians will spend probably their staff members 2 full days of their staff to take care of pre-authorizations. So you can see how physicians are burdened by this, and 88% of physicians feel they're burdened by this pre-authorization. When I practiced and started in 2000 of this, there was probably when in private practice, you need for one physician, you needed five providers, staff members to help manage that physician's practice. Now, for one physician or clinician in our practice, requires 12. So you can see over the last 20 years, we double, triple requirements on staff members to help support this physician's practice. And this is a problem and impediment that no one understands. And I hope to impart that to everyone that's hearing this podcast. Now, here's a good example from ProPublica. ProPublica has determined that Cigna saves millions by having doctors reject claims without reading them. And I would argue, well, it's not doctors that are doing this. They have bots. They have a program designed that will go through the charts and make quickly corrections or denials based on words. I mean, I got a patient that has been on cannabis for a pre-certification for a spinal swimmer. It got denied, and I had to do a peer review, spending 15, 20 minutes explaining to the doctor that they denied it because the patient had cannabis. So, well, it is cannabis, but it's cannabis used in my state of Pennsylvania in medical direction for proper use and this for pain control. And that's what they denied it on, just because of cannabis in the chart. So to me, it's a problem, especially when you have these active companies using these abilities to deny care just because they can. And this is the problem that Cigna and many insurances do with these bots that kind of deny our care, even though, and most times I do the peer-to-peer patients, they don't read the full chart. They never do. And then they say, well, at the bottom it says it right here. Well, they didn't see that. So I don't blame sometimes the medical directors, people that are reading charts, but they're not reading these charts, period. Peripheral nerve stimulation, a treatment and option we have offered patients who have failed severe pain and intractable neurologic pain, nerve pain. And we are now have Blue Cross Blue Shield in Tennessee and multiple carriers that deny this, even though Medicare and Medicaid covers across all regions of the country. And even though we committed, and I've been part of this on publishing consensus panels, recommendation guidelines supported by multiple pain societies, neurologic societies, neurosurgical societies that support its use and need for patients, they still deny it. So if I can, as a physician, can work through my science to get the proper guidelines, proper science recommendations, and they still deny this, what are the options? And that's where we have to say, we've got to do something else. So the Federation of Pain Care Access, as my mission statement, developed a group. I would say Dr. Cloth, Dr. Kalai, myself, and multiple people on the board now have decided we got to do something for this. We are losing. We're not helping patients. We've lost control of our profession. We got to do something for helping these patients with severe intractable pain. So as part of what we do selectively, because we're a small entity, we do work with all the medical sides. I'll show you in a moment. But we're meeting with Medicare and Medicaid, so Center for CMS. We also working for the MACs, we call Medicare Administrative Contractors with different regions, trying to improve on care. One of the things we're working on is something called circular joint radiofrequency ablation. What it
That's
is,
important. That works. And it's such a sad thing that they're not approving that.
I know. And so we have, and this is one of the big things we're trying to be very specific what we do with our entity, kind of get this coverage because it works. We know it does. And I'll tell you how we're going with this reconsideration. But what we have is we have a lot of the state societies. I happen to be one of the Pennsylvania Pain Society. We have multiple. We have probably close to 18 beyond this that are proven are working with us to get better pain care access, not just from a national level, but also regional and a state level, as you can see. So we have collaborated with all the major pain societies, American Academy of Pain Medicine, American Society of Anesthesiology, North American North Spine Society, Regional Anesthesia Society. So these societies are big in our field. Not only that, they also have lobbying efforts. They have abilities to talk to legislators, but we work with them trying to get these things approved. We're on the same board with what we just said. So we have worked with Robin Hoyle, who's an attorney, also helps with the state societies. We've worked with Michelle Byers, who works with ACIP. We're working with a very specific, well-known Dr. Rudolph, who's also worked for CMS, is helping with consulting for trying to get these things across. So when we look at identification in the pain space, interventional, SI joint radiofrequency ablation is a big thing for us. We feel the criteria for facet injection ablation, get 8% relief, is just too high. We know most societies, 9 out of 10 societies say 50% is just fine. We do have an issue with the fact that they only limit on 2 levels, which I understand, and which is if you have a neck and back problem, you should be able to do more because they're 2 different entities, but they won't let us do that. Requirements of documentation is pretty dramatic. I don't want to go more in details. I could spend 50 minutes discussing that per se, but it's a problem overall that they won't even do the documentation is just so much to get this done and approved.
I find also when it comes to the facets, it's the whole with the 2 diagnostics and then the follow-ups between this gets dragged out over 2 months easily.
Right. Correct. And this is the problem. This is why it delays care for these patients. And what happens, David, to those patients who don't get have these treatments? What happens to them? They get put on medications.
Yeah, opiates.
Opioids.
Yeah,
And I thought that's what we're trying to reduce that. But they gotta function. These patients have to function. They have to go to work, got to do things, and they're in pain. And this is what we hope these procedures will help.
sure.
That's why we do it. So, having said that, we met with Elizabeth Trung at CMS. I was there in March of 2025. When our meeting, we spent very much particular about this SI joint radiofrequency ablation. She is on board with this, and ultimately, we have a meeting with the MAC medical directors. She's agreed to discuss with the MAC directors why we can get this reviewed, and ultimately, we know that we have 2-year data from SI joint radiofrequency ablation, which is being submitted for publication. We hope to present this to them to have them reconsider this procedure as medically necessary, be able to offer this for patients when we know it works. Because ultimately, these people with SI joint pain, this is a problem, and we think we can challenge this from previous analysis conclusions. We would say currently with conclusions right now, every society I mentioned to you approves this, recommends this, and we now have more evidence to support this and have the medical directors change their decisions. So the big people that are doing this is Dr. Provenzano and Dr. McCormick is working on this as well. And we believe we can get this approved, but we don't know. We also believe with the new CMS director, Dr. Mehmet Oz, who I'm very familiar with, is hopefully going to be able to talk to them and discuss how these over-aggressive, unnecessary audits and predetermination is a harm for patients. It's the reason why we're losing, trying to give patients better care. We'll continue further discussion with patients. We know this entity with a reversing ablation of the SI joint is just one thing we think we can help with overall. But we need funding. We need to support ourselves. We need to also grow our associations, affiliation with different societies. I thank you, Dr. Rosenblum, for the fact that these podcasts and other podcasts are valuable, get this message across. We are continuing to improve on our website and coverage in social media and cross-border in terms of marketing. And I think you'll find that doctors, physicians have realized, and you are a good example, Dr. Rosenblum, that we have to get this message out there. We have to do more than just take care of patients. We have to be able to talk to legislators, talk to the carriers, but we also have to educate the patients and society on what we're dealing with to help them get better care. Federation Pain Care Access is a 501c3 nonprofit. It's not supported by industry. This is very important to us. We're not supported by industry. We're not supported by pharmaceuticals. We're supported by providers, patients, advocates for patients. This is what we're trying to do to get this in place. We're a small operation. We desire to expand. Everyone on the board is voluntary. We don't get paid by any means for this. These are current societies that have donated to us financially. These are to the right, also some of the individual providers that donated to help support this cause. But the thing that we have is all the fundraising across the board is understanding that we have all the states, national physicians, and patients that support us. We want to do a foundation, a 501c3, which allows us assist in supporting through individual and private foundations across the country to help support this cause. I can't tell you how many patients and how many people that have been affected, harmed by this process with pain care. And this is why we exist with this foundation, also with this entity. This foundation board will be developed this year, 2025. It will be separate. We'll maintain this in relation to kind of maintain this mission we spoke about. The use of funds is just like this, but here's a key part about this, which will be separate as the C6 is we are interested in, if we can't get approach, unfortunately have to take the other routes and other options of litigation and legal approaches for this. And that's really the only way, in my opinion, that we get things cross board and get a message across. But I hope you understand, David, through your audience, how it's very important. Pain care access is important. I believe it's valuable for these patients. It's valuable to give them some alternatives than prescribing opioids. And I hope we will make a difference overall. And David, I left it so that we have some time in your time for the podcast to answer questions. Do you have questions? Anyone you think can recognize that we do as a group can make a difference for patients. Thank you.
Thanks, Phil. I mean, that's amazing. I mean, on behalf of the pain docs and the patients, thank you, because we really need this. I went with Dr. Kalia and a group of other doctors, Dr. Stats,
Yes.
to DC last year to talk to representatives of Congress for the about IROs, independent review organizations, and the whole sham that is.
Yeah.
Basically, they denied every single request for a peripheral nerve stimulator. And if you're going to deny everything, what's the point?
Yeah.
So this is the cards are completely stacked against us. And I don't know how the government let this happen, but it's happening. I mean, look at what happened to that CEO who was killed. People are
That's
angry.
right.
That's not justifiable, but there is a lot of anger about what's going on here and the fact that our hands are tied. We have these great therapies like
Yeah.
SI joint ablations and many more. I mean, that's
Yes.
big. I think that's a good one to start with because it's
Yeah.
an obvious.
Right. And so the societies and through the investigators have 2-year data now we can submit to them. Because I was concerned before that we didn't have long-term data. We have now long-term data. We can show them this. And I hope these medical directors can hear and read this out and understand that we have evidence. But I would always ask these medical directors, the people that make decisions, what are your alternatives for these patients? And the fact is Congress has heard about our issues. That's why this called a No Pain Act. I don't know if you know, in December 2022, they passed, they it was a co-sponsible, bipartisan co-sponsored on providing expanded access to non-opioid alternatives for the outpatient setting in acute pain. And it actually is active as of this year. But they understand that we need to give alternatives to patients in pain, non-opioids, because if you don't give them these alternatives, then they will use opioids.
Right.
And this is, I'm not opposed to opioids. I think opioids work well in the right patients and what we regulate and use for these patients, but we got to give them other choices. And that's where I'm hoping this entity will help. But sometimes we will go through all the standard routes. We will meet with the societies. We'll talk to the legislators. We'll do some lobbying efforts. It's a slow process, but I got to get this message across because the reaction to this guy being assassinated, which we both totally agree are totally unfounded. We totally do not agree with this, but it shows that people's response to this is they're all frustrated too. Everybody's frustrated with these issues with the carriers, and I just showed you why they should be. But it also is concerning for me that because it's so hard with pre-authorization, not just in the pain field, that almost 40% of doctors are opting out of Medicare, if you didn't know this. Huge numbers of doctors opt
Right.
because they're just tired of the whole process of going through this pre-authorization, predeterminations, and the requirements to get paid. And
Hmm.
that's the sadness to me that we have a group of people, elderly, that work very hard in their life. They just want to get care. They paid into the system. They want care. They won't forget it.
Yeah.
So, right.
Yeah. I mean, you need an army of people to get anything done. I think ever since Obamacare, that army doubled. It got much bigger.
Yeah.
Um, and I guess after you guys hopefully successfully get the SI joint approved, what else what's on the schedule?
Yeah.
What else would you guys target?
So on the schedule target, because we think that there is clear evidence which um, is supportive for us, is SI joint, I mean, the radiofrequency frequency ablation for the lumbar facets. Remember, the facets are those entities, the hinges on the side of the back, which cause axial back pain. It's a very common joint that causes pain. There's really no treatment for this beyond just medications. Injections are really done for diagnostic purposes, determine that's where the pain's coming from. The ablations work. But for them to tell us for CMS and these MACs that you only do two levels, why? What's that based on? It's based on nothing. There's no science. All the clinical studies that are doing this supported the fact that you should be able to do more than two, three levels. What if you have a back problem and a neck problem? Why can't you do both? No, they won't let you. Where does that come from in terms of science? It doesn't come from anywhere. If a neck and back problem should be treated independently, which is true. But the fact is, they made this number of 80%. That 80% rule is not well established. And quite frankly, many of the studies were going to 50% relief. So when they look at these numbers and they tell us overall, this is what I don't understand. 80%, 50%, yeah, it's a measure for studies, a measure for determining a result for a study or a supporting hypothesis, but that's not the reality. The real world is very different. People will be very happy to get 50% for the back pain, especially if I can improve their functional abilities. I get them off medications. The quality of life's better. The
Oh yeah,
50%. And
absolutely.
that's why I don't understand these numbers. And they pick and choose these numbers, to in my opinion, to support their cause, to deny care for these patients. And that's what bothers me with these numbers across the board.
Well, another thing, which I don't know if it's unique to pain management specialty, but
Yeah.
I find somebody comes to see you for, let's say, knee pain. You do the visit for knee pain, but they won't pay you to inject the knee that day. You have to
Right.
pick or choose. You could
Right.
build a follow-up or a new patient code or the knee code. You
Yes.
can't get paid for both.
Right.
And that's
So
ridiculous.
it's ridiculous because there is a modifier called minus 25, which lets you do both a procedure and an office visit. So the people with the CMS and these MACs believe that, well, your visit, you didn't need to do that, which I think is ludicrous because ultimately, sometimes when you do a knee injection, you're also then going to work on exercise and mechanics, you're going to do medications, which are separate from the procedure. And so for the providers out there that have this issue, the way you can only get around this in terms of billing for a EMM visit plus a procedure visit, you have to have different codes for the procedure versus the injection. If you do an injection for the knee, fine. Build that code for the knee injection and use that code. you could probably want to use a different code for the regular office visit. And that's where you get around it. But if you
You mean a
put the
different diagnosis, like if
different
they're
diagnosis codes,
thing
right?
as well,
You
yeah.
use the same diagnosis code, they'll flag it and they'll say you can't do both.
Yeah. It's just a shame. I know that in
Yes.
other systems, such as the Canadian system, through some consulting experience I have there, the radio frequency ablation is a no-brainer. It's like
Yeah.
you could do SI joint, you could do it, you could do I believe there is a limit to the amount of levels,
Yes.
but you could do it fairly quickly. You know,
Right.
you could do a lidocaine this week and then next week go straight to the ablation.
Right.
So,
Yeah, and the in the facet arena, you want to have usually 2 weeks. There's a global period,
right.
and and I don't understand if they say that the maximum is you can't do another one for 6 months, which I think is ludicrous. So I got to wait 6 months to another level. Um, and then I have to establish the amount of response. I got to put this all in documentation. You have to show that you failed conservative therapy, you have to fail physical therapy. I said, well, I said fail physical therapy. Well, we don't have your notes for physical therapy. I said, what do you mean? Patient had physical therapy. It's not in your chart. They had physical therapy. I said, well, did you read the previous records? It's in there.
Right.
They don't read those things. They need to show, they need to make it easy for them to do their evaluation. I said, well, if you are doing a predetermination, I expect that you go through our chart and records, go through the previous records. Physical therapy script is in there.
Yeah.
So that's what they make it so difficult to get this approved for patients. And somehow patients somehow think, oh, well, doctor's just going to call them and answer and they'll get all approved. No, it doesn't work that way. They tell patients, these carriers through their representatives, how easy it is and this and that. It says, oh, it's our fault because we're not doing all this stuff. But patients don't understand the time and effort. A lot of practices in my area, they charge predetermined peer reviews. They charge like $40, $100 to do pre-authorization time.
To the patient.
Patient.
Really?
I have practice in my area that charge a patient. If you want a medicine that's off their formulary, they need a predetermination, pre-authorization. They would charge the patient $40 for doing the pre-authorization.
I tell you what, that makes sense. I mean, we don't do that, but
No.
if I'm paying an employee to spend their time and not do what, clinical care or whatever else is needed, I think that makes a lot of sense.
Well, the truth is our field through legislators and the legal societies, they've actually made us more into a legal practice. Let me tell you what I mean by that. In the past, doctors were paid very well 20, 30 years ago. My dad was a retired gastroenterologist. He practiced for 60 years as a gastroenterologist in private practice. But he never charged patients for phone calls, never charged
Right.
patients for filling forms and documents. What happens now? We fill it now because it's taking time and effort from our practices. Even doing a certification for a medical cannabis in the state of Pennsylvania, we do charge some amount because I tell patients we do this because I need staff to prepare the chart. I got to view the records. I got to put the documentation properly. It takes time.
Mhm.
And so every practice I know, whether it's a primary care practice, a pediatric practice, they're charging for a regular physical exam requirement for physical activity in schools. They're all charging. And that to me is a problem because never used to be in the past. But in reality, we require more staff members. Remember, I told you staff members for a physician when I was started in 2000 was 5 staff members for one physician. Now it's 12 to 1. It's
Crazy.
gone up, right? And then people don't realize that in practice, to add to this aspects, when we went to electronic medical record system, you would think it would save money, save effort. No, it just changed where the money goes. It changed the fact that we're spending money on IT and services for IT, requirements to have
Security, all that. Yeah.
all that stuff, which is a problem. That's where the money's going for practices. That's where our money's going to this all. And then we added a division in our practice, one division for pre-authorization for imaging, one division for pre-authorization for medications, one division of pre-authorization for procedures. So you can see how the staff members have accrued in terms of helping a practice run. The entities in academics, these large groups, have that abilities, but trust me, it's not as like it's for free. We're not getting paid. We're not getting any support from the state, from federal about these cost issues. We're just being charged as an arm and a leg.
Yeah. We're unfortunately we're an easy target.
We are.
we're not very savvy legally. I mean, thank God we have guys like you doing this sort of work because of we need to unite, we need awareness, and we do, and you guys need support. So, I mean, I
Yes,
hope
sir.
everybody listening to this will donate or at least spread the word and help. I'm sure there are some wealthy patients out there who would be more than happy
Yeah.
to contribute because they understand what pain is like. And yeah, whatever I can do to help you guys, let me know. This was great having you here. Thank you for coming on the show.
I want to thank you so much, Dave, for what you're doing. What the mission is. I'd like more doctors to be involved outside of the field. I think when we both took the Hippocratic Oath about what we did, it's not just for our patients, it's actually for society. And I want to make sure that we get the message. Your podcast, everything like this is very helpful. I know the time effort and you do this beyond your regular full-time job. It's valuable. And docs have to know this. Yes, we need more people to serve in Congress, we need more people to serve in lobby. We need more people to get the message across like you're doing to show that this is important. We take care of these patients.
Great. Well, thank you, Phil. Thanks for coming on. And I'll have the link to your website as well as information about how they can contribute.
Thank you so much, David. Take care.
Take
Bye-bye.
Good day.